and thank you, Sir Victor and Wellbeing, for the invitation to speak at this always enjoyable occasion. The Wellbeing Women annual luncheon debate is always an event to relish. With great friends, great discussion, great lunch, and underlying all, the great cause to which this charity is dedicated, the improvement of the health of women and babies. As the mother of 2 sons, each now with one small and adorable son of their own, and as a woman who has been successfully treated for cancer, I'm deeply aware of how much of my own personal well-being is grounded on the good health of my family and myself. So I salute the many contributions that Wellbeing has made to improving the health of women and babies over its first half-century through its investments in research, of which we saw such a compelling lineup just now. I'm also very grateful for the support that Wellbeing gives to the work of a small charity called Addenbrooke's Abroad, which I have the honour of chairing, which works to improve neonatal health outcomes in El Salvador and now in other countries in Central America. It's also a great pleasure to see the Honorary President of Wellbeing, Sir Marcus Setchell, here today, though he does remind me, his presence reminds me of the faint alarm he gave me when, in 2012, he invited me to give the George Pinker Memorial Address. Very grand affair. Yes, grand list. And he suggested to me the subject of the fragmentation of women's healthcare. My alarm arose from 2 factors. First, my qualifications for speaking about healthcare are slender. I have no medical or nursing background. As I was reminded soon after I got my PhD, when I went to work over one long vac at Brookhaven National Laboratory on Long Island. The amiable porter, who helped me carry my bags up to the girls' dorm, looked at my new luggage labels, proudly inscribed Dr. Mary Archer, sighed, and said, "You a real doctor, missy, or you kind of doctor never did no good to nobody." I had to admit I was the latter kind of doctor. And years later, when I chaired Cambridge University Hospitals, I discovered the complexities of looking after more than 1,000 of the real kind of doctors to be considerable, requiring every skill I had, as well as quite a few I didn't. The second cause of my alarm was that the term fragmentation was new to me in the context of healthcare. But as I thought about it, I realised that I knew the phenomenon all too well through seeing aspects of it while I was at Cambridge University Hospitals. And now I have links with other parts of the health service, notably Imperial College Health Partners. I see other aspects of this damaging phenomenon, which in my view can be grouped under 4 headings. First, there's longitudinal fragmentation of a woman's healthcare along her life course. Secondly, there's clinical fragmentation of her care as between generalists and specialists. Thirdly, there is organisational fragmentation between community, primary and secondary healthcare services. And lastly, and most damagingly, there's financial fragmentation, one might almost say a chasm, between the funding arrangements for health and social care in this country. Looking first at longitudinal fragmentation, healthcare today tends to be episodic, dealing with the present issue and not what might lie ahead, or what lay in the past and may influence the present. Although that's less than optimal for both women and men, it presents more of a challenge in women's healthcare because their needs are more predictable and they also tend to have more frequent interactions with health services, particularly if they have children or other dependent relatives to care for. For example, there's the role of GPs, or rather the lack of it, in the care of women during pregnancy. The move of antenatal care from GPs to midwives, which came about with the Changing Childbirth initiative of the early 1990s, had the laudable aim of creating a woman-centred service. But it also had the possibly unintended consequence of separating GPs from their pregnant patients. Thus, it can be that GPs don't get to hear about any complications the women on their list have suffered during pregnancy. But they really need to know about these. For example, roughly half of the women who experience gestational diabetes during their pregnancy will go on to develop full-blown type 2 diabetes within 10 years. And the 10% of women who have hypertensive disorders during pregnancy will have double the risk of future cardiovascular disease, as do the rest of the female population. If a GP doesn't know that their patients have had such complications in pregnancy, they won't be alert to look out for those increased risks in later life. The second problem I mentioned is the fragmentation of clinical care as between generalists and specialists. The current configuration of healthcare largely reflects the development of separate medical and surgical specialties and subspecialties, which is, in the main, a very good thing. After all, nobody wants to be operated on by a surgeon with inadequate specialist expertise. However, were you to have the misfortune to be living with three, as it were, unconnected long-term conditions, say heart disease, COPD and diabetes, you'll be seeing at least 3 different specialists in your visits to outpatients. They're very unlikely to be working in a multidisciplinary team, as now do the specialists who look after people with cancer. And they will effectively be treating a part of you rather than the whole of you. Of course, specialists are an essential component of any modern healthcare system, but there can be failures in care where there's no one in overall charge of a patient with, to use a little medical jargon, multiple comorbidities. Occasionally these failures can be catastrophic, as in a sad case I remember all too well of a Danish lady called Mrs. Bo Pagano, who was in Addenbrooke's Hospital being treated for rheumatoid arthritis and sadly died while in our care because we failed to spot she had developed septicemia until it was too late. The most common way of dealing with this problem about no one in overall charge is to have one named consultant in charge of each patient during their hospital stay. At present, about 40% of inpatients have such a named consultant. Another approach, which Secretary of State Jeremy Hunt has called for, is the introduction of the so-called hospitalist. These are physicians who don't practice specialist medicine, but instead monitor, develop patients' individual care plans, see that those plans are going according to plan, and also make themselves available to talk to the patients about how they're doing and also to talk to the patients' relatives. The third of my 4 troublesome fragmentations is the organisational fragmentation of care between community, primary and secondary health services. We're all familiar with this, whether it's through going to A&E rather than contending with unfamiliar out-of-hours services, or difficulties in getting a referral from a GP to a hospital diagnostic service, or having our discharge from hospital delayed because the care we need at home hasn't been put in place. Simon Stevens, the relatively new Chief Executive of NHS England, has highlighted this problem by repeatedly calling for reform of the traditional system of GP surgeries being totally separate from hospitals, saying it's past its use-by date because it means that people with long-term health problems are passed from pillar to post between different parts of the health service with different objectives. It's much easier to diagnose this problem than it is to solve it. After all, no matter how many times the great leviathan of the NHS is organised and reorganised, it must always contain many boundaries between the very many building blocks of the system. Community care services in your area, GP practices, mental health services, hospitals, clinical commissioning groups, each with their own increasingly constrained budgets. As patients move between these different organisations in their local health system and NHS funding follows them, the superstructure of tariffs, incentive payments and fines for failure to hit performance targets can produce quite perverse financial incentives that can, for example, make it cheaper to keep a patient in a hospital bed after their episode of clinical care has finished than it is to discharge them to intermediate home or residential care. The approach that's being adopted to solve this problem is to blur the boundaries between those different organisations by creating partnerships that are incentivised, usually financially, to work together to provide joined-up care for patients. For example, in my home county of Cambridgeshire, a partnership between Cambridge University Hospitals and the county's Mental Health Trust has a 5-year contract now from Cambridgeshire Clinical Commissioning Group, the people who hold the purse strings, to provide an integrated acute and community service for older people. My last fragmentation, that between healthcare on the one hand and social care on the other, is the most troubling. And it impacts more on women with their longer lifespan than on men. And although, or perhaps because, women do live longer than men, they suffer a greater burden of unhealthy life years. Some elderly women leaving hospital will need to go into residential care, and others will need social care. That is, assistance at home with everyday tasks. So healthcare and social care need to work in tandem, but they don't. There are really huge difficulties with marrying the NHS, taxpayer-funded and universally free at the point of need, with means-tested access to social care funded by local authorities at a time of sharply dwindling budgets. Hence the current interest in so-called integrated care organisations, ICOs, in which organisations across the different health and social care sectors in an area pool part of their budgets to commission integrated services for a time for population groups with similar needs. In the London Health Commission report, Better Health for London, published last year, Lord Darcy recommended that 15 ICOs be set up across London, and I think we're likely to see the 3 London academic health science networks take the lead in putting those into place. Thank you for allowing me a few minutes to reflect on my experience in the NHS as chair of a major teaching hospital. Now I look forward to a new challenge, chairing the Science Museum Group, which comprises not only the Science Museum in South Kensington, but also the National Railway Museum in York with its great steam engines, one of which you can see behind King's Cross Station in the Railway Children, incidentally. The National Media Museum in Bradford, and the Museum of Science and Industry in Manchester. I've been a scientist at heart all my life. I conducted, I'm told, my first scientific experiment at the age of 10, when I tied an earthworm into a knot to see if it could untie itself. It could not. So in coming back to the Science Museum, where I was a trustee in the 90s, I feel like a child who's been given free run of Hamlet's toy shop. However, the NHS has got into my bloodstream, so I'm particularly pleased that among the plans for the Science Museum is a major new medicine gallery, showing not only the great historical artefacts that come from the Wellcome collection, but also current and emerging trends in medicine. May I end by saying it's been a privilege to speak to you today, and I wish Wellbeing of Women all continuing success as you enter your second half-century. Thank you.